Thank you, Tracy. Okay, we have a good amount of folks joining. So that's lovely. And we are at 2 after. So I will just go through and give introductions. Hi, everybody. Good afternoon. Thank you for joining us. We want to welcome our guest, but many of you may already know Gene Ransom from MedChi. He's been a good partner to Mac on issues that we have in common and whether it's advocacy, but today him and his team, Olivia Simon, are going to talk to us about EQIP. Some of you, at least one of you I know of, is already in this program. But there's certainly advantages to the program, and by far, MedChi is the expert in how it works, and he has offered to share a little bit more with you today. So, without any further ado, welcome, and we just really appreciate you flagging this opportunity for us. So, thank you, Jean and Olivia.
Thanks, Nora. We really appreciate the close partnership we have with Mac. You're really important partners to us, and we're so aligned on so many things. In fact, I can't think of any time we've ever been cross. So that's pretty impressive. I can't say that for other organizations. So today we're going to talk about EQIP, and the exciting thing about EQIP is early on when we first helped create it. In fact, when we first helped create it, it was really the HSCRC, which is the Health Services Cost Review Commission, MedChi, and CRISP. They were the three groups. And in fact, I have chaired the state's EQIP committee since its very inception. But when we first started it, it was really focused on a handful of specialists. It's focused on GI, ortho, cardiology. So it really wasn't an FQHC or primary care play. But what happened is over time, we've added more and more bundles, we've expanded it. And when the Maryland Primary Care Program and some of the other programs were not advanced payment models anymore, we realized it was really important to add bundles that primary care doctors could take advantage of, primary care practitioners, nurses, others as well. And that was really, we did that several years ago. So that means that actually you can take advantage of it. In fact, we've had some primary care EQIP entities have savings and do very well. And Olivia is going to go through the details on EQIP today. She really is the expert and the main person you should talk to. The other thing that's really nice about this is that CRISP and MedChi both have contracts from the HSCRC to help anybody sign up for free. And to just steal the biggest takeaway is there's three ways you can make additional money. The risk is borne at the state level, not at the entity level, so you're not at risk, but the state is. So you get the benefit of being an advanced payment model, three different ways you can make additional revenue, and we'll help you sign up at no cost. So it really makes a lot of sense to have the discussion about this. So without further ado, I'm going to turn it over to Olivia and I'll let her introduce the rest of the team and I'll let her get going. Olivia, it's all yours.
Thanks so much, Jean. Hi, everyone. Thank you for being here today. Before we get started, as Jean mentioned, I'm on the MedChi EQIP team. So going to be going through the overview of the program today and then here as a resource if you would like to learn more or would like to sign up. We also have a representative from the CRISP team, Angelica, on the phone today as well. So she will be speaking to some of the next steps related to actually signing up for 2027. So we will finish the slide deck with turning it over to Angelica. So we're going to go ahead and get started. If anyone has any questions along the way, feel free to write them in the chat or you can come off mute and ask them. All right, so before we get into the presentation, I want to take a moment to just talk about why you should even consider signing up or learning more about EQIP. And Jean mentioned this a little bit before, but as an EQIP participant, you are able to obtain QP or APM participant status. This is really important because QPs are exempt from MIPS reporting, and they also receive conversion factor updates to their Medicare payments, to their Medicare physician fee schedule. This is simply by just being a part of an advanced alternative payment model like EQIP. You also have an opportunity to earn an incentive payment or a portion of any savings that you are able to generate in this program. And this is a claims-based reporting program. So there's no additional reporting requirements or extra work that would be involved as a participant, which is really important. So I also want to take a moment to just talk about the history and the impact that EQIP has had since its start. Jean talked about the creation of EQIP back in 2022. And since then, we have continued to see success, reducing overall Medicare costs and also meaningful incentives to those participants. So if we look at the statistics of this program back in its first year, EQIP generated $20 million in Medicare total cost of care savings, and most recently in 2024, $62.6 million in Medicare total cost of care savings. The incentives to participants has also continued to grow. So in the first year, 13 million was paid out to all participants. And then in the most recent 2024 year, 29.1 million paid out to participants. We've also seen a lot of growth in just participation. Jean mentioned the increase of episodes and opportunities for different types of practitioners. And we can see that in these numbers. So in the very first year, just under 2,000 practitioners were involved in this program. And now in 2026, currently, there are over 5,000 practitioners participating. So it's a great opportunity. And I'm really excited to kind of walk through an overview of the program with you today. All right, so we're saying EQIP. What are we talking about? So EQIP stands for the Episode Quality Improvement Program. This is a value-based Medicare incentive payment opportunity specifically for Maryland practitioners. I just mentioned this on the earlier slide, but EQIP is, again, considered an advanced alternative payment model, and it engages practitioners who treat Maryland Medicare fee-for-service beneficiaries through an episode-based approach. So we're going to break this down and talk about how EQIP operates. When you sign up for EQIP, you enroll in an EQIP entity, and then the entity is held accountable for achieving both cost and quality targets within one or more clinical episodes, Entities then will have an opportunity to earn a portion of the savings that they generate in their episodes as a lump sum incentive payment. Before we move on, I think it's important to define two key terms. So the first is an EQIP entity. When you sign up, you enroll in an entity which consists of one or more practitioners. And this group, or one or more practitioners who decide to participate together, will be evaluated in the EQIP program at the entity level. The second key term is a clinical episode. An episode is a defined period of care for a specific medical condition, procedure, or treatment under EQIP. So we're going to talk next about some of those clinical episodes. So we just defined what the episode is, and again, we're looking at the medical conditions, procedures, or treatments. But it's important to understand how each episode is structured. So in the center here, episodes have a trigger. This is when the initial care was first performed. Then we have the look back window. The look back window is a specific time period before that triggering event, in which all costs related to that trigger will be included. And then we have the close period. This is a specific time period after the trigger event, when all relevant costs related to the trigger will be included. This makes up the episode period, or the episode length, in which all relevant costs will be included for the EQIP program. As Jean mentioned, we've seen a lot of growth. In 2027, the program will actually offer over 140 clinical episodes from the following clinical categories. I do just want to note the episodes are organized by clinical category, but there's no limitation to the type of practitioner that wishes to enroll in EQIP under one of these episodes, as long as they meet the eligibility requirements that we will talk about later. The Performance Year 6 2027 episode playbook is in development and is coming soon. And we'll be able to share this resource with you once it's available. And this playbook will essentially define all of the episodes that there are to choose from for 2027. So you can really look at what are your options, what makes up the episodes, what are the trigger codes, what are the episode lengths associated with each, and that can help you make a decision. One, if this program is right for you, and two, what areas you may be interested in actually participating in. So although we don't have the PY6 playbook ready for you today, I did want to go through just an example of what you can expect to see in the playbook when it is available. So this is from the 2026 playbook. And this is an example of one of the chronic episodes. For today's example, we are looking at osteoarthritis, but all of the episodes will follow the same format. So in the top right, what we're looking at. Oh, do we have a question? Sorry, I thought I heard someone ask a question. If anyone has a question, feel free to come off mute. I'm gonna continue. So on the top right side, we see the trigger codes. This again is the time when the initial care was first performed, the trigger. The codes are either going to be ICD-10 codes for the chronic episodes or CPT codes for any procedural episodes. These are the specific codes that the EQIP program will use to identify that the episode has been initiated. So again, we're looking at osteoarthritis as an example. Each episode will have unique trigger codes. Then in the bottom left, we see the episode length. On the left side, we see the look back period. And then on the right side of the trigger, we see the close period. This is the specific time frame when all of the relevant costs will be included in the episode. So for this particular episode, there is a 30-day look back from that initial trigger event. And then because it's a chronic condition, the episode will continue until the very end of the study period or the end of the calendar year. I did just want to show one other example so you can understand the difference between the chronic and the procedural episodes. So same exact thing, you see the trigger codes here, but they are CPT codes. And then for any procedural episodes, the time frame specifically in the close period is not going to be until the end of the calendar year. It's going to be a specific amount of time. So for this particular episode, we're looking at a 30-day look back and then a 30-day close period. Again, this is making up the time when all of the relevant costs would be included for the episode. So just as a reminder, these are just two examples. I'm really just showing you so you can understand how the playbook is set up and the codes and the episode lengths are displayed. We will be sure to communicate once the PY6 playbook is available so you can go in and look at the specific episodes that may be of interest to you.
Excuse me, Olivia, this is Jackie Dujay from the City of Frederick's Community Health Center. I have a question. Now,
Yes.
the prior slides, you had shared the different, I don't know if they were specialties. I'm just wondering how the FQHC fits in to these specialties, these episodes and these clinical categories.
Yeah, that's a great question. So we have over 140 different episodes that fall under these clinical categories. That's just the way the program kind of organizes them, structures them. But you are likely going to be able to participate in various episodes that, fall under these categories. So let me think.
Olivia?
Yes.
It's Nora. I think it may help. I think some of the one of the centers that we have is participating in the emergency department one, or something
Okay.
with emergency departments. And then when I was looking at this, OBGYN could be another easy one, but there could be others. Behavioral health, who knows?
So
Thank
I guess what I'm trying to understand is, like, for example, my health center, we would refer out for many of these. So I don't know if it's our client who then who went to the hospital for a GI issue or went to we had referred. I'm just wondering, like a primary care provider, like how did they fit into this time frame related to these clinical categories? I mean, we do have a behavioral health specialist, but we don't necessarily have any of these other specialists right now. They would have to be referred out.
And yes, that's a great question. I think seeing the episode list would be helpful because I think you'll see a lot of conditions that maybe so I'm trying to think off the top of my head, but like diabetes is one that a lot of the primary care groups participate in. Low back pain has been one. There's I think cellulitis, one of the dermatology episodes, some of the allergy ones like asthma, maybe. So I think there's a lot of overlap. And if your, practitioners are the ones that are attributed the episodes, even if, the patient then goes to see a specialist, if you are attributed the episode, then you would still be like counted for EQIP. And then the care at the specialist would also potentially be included as long as it's, considered relevant. And I'm going to kind of touch on that on the next slide related to the episode costs. But I think there's a lot more overlap and it might just be helpful to see the full list. And I'm even thinking what I can do as a follow-up, because we're going to send all the materials out. I can send you the list of the episodes. We just don't have the definitions to share with you yet. Do you think that
Let
would
me
be
also
helpful?
suggest this, if you don't mind, Olivia. So,
Okay.
one of the things we do for the primary care doctors that are interested is we will run an opportunity analysis. And I think Angelique will probably go over how that works. And then we can see what you qualify for. And then strategically, we're happy to sit down and go, you know what? We probably don't want to pick the cardiology episodes because we have no control over them. However, lower back we're qualifying for, and we're managing these Medicare patients in our FQHC and trying to keep them out of the hospital and trying to keep the total bundle cost down. So we suggest doing that and then looking at what you qualify for and then making a strategic decision about where your clinicians could make a difference or make an intervention. And one of the things you want to be careful about is if your FQHC is right next to Hopkins or Mercy that have very expensive GBRs, you want to be careful about picking things where they're going to be going into those hospitals with very expensive GBRs because that could blow up the whole bundle, right? But we can have those kind of discussions once we see what you qualify for, and we can simply take your list of NPIs and then run the list, and then we can make an intelligent decision. You guys are very, very capable of managing diabetes, behavioral health, lower back pain. Those are things that primary care doctors manage all the time.
Thanks, Jean. I think that's a great recommendation of submitting your, NPI list and just seeing where there even is opportunity. I think I see something in the chat. Oh, okay, perfect. Just want to make sure. All right. So I'm gonna move on and talk about the episode costs. So we discussed what the episodes are, how they're set up, their lengths. But it's really important to take away from this that the episode triggers and all of the related costs are going to be identified based on your traditional Medicare for fee-for-service claims. So there's no additional, work or reporting that you need to do to track your episodes. It's all based on your standard billing. So the total relevant costs for the episodes are going to include the Medicare Part A and B payments for any services that are clinically related to the episode and occur within the episode's time frame, regardless of who provides them. So this is what I was mentioning a little bit earlier about being the attributed practitioner. So we may see, you're the attributed practitioner for a diabetes, low back pain episode because you're maybe seeing that patient most frequently. But then if they go and see a specialist or another healthcare provider for that same condition, and it's within the episode's time frame and it's considered relevant to the episode, those costs may also be included in the overall episode costs that would be assigned to you as the participant. So some examples of what we're talking about are listed here: inpatient, outpatient, imaging, labs, Part B, other physician services, and DME if it applies. So just want to get you to start thinking about, what episode costs are included. again, more information will be available in the playbook once that is published. Okay, so now that we talked about what's included in the actual episode cost, I want to talk about how you are evaluated on your cost. So your performance year or your 2027 episode cost will be compared to a target price or a goal price. The cool thing about EQIP is there's not one goal price. So there's not one target everyone has to meet. It's actually a unique target price that each entity is going to get for each episode it selects. And this target price is calculated based on the entity's average episode cost during the baseline year for EQIP, which is currently calendar year 2019. I do just want to mention, it's not on this slide, but the ED, the emergency department episodes, any of those that fall under the ED clinical category, the baseline period is actually calendar year 2023. That is the only category of episodes that did move up. All of the other episodes are currently using 2019 as the baseline year. So then what will happen is the performance year episode costs are going to be compared to this target. If the performance year episode costs are less than the target price, then you have generated savings or your cost target has been achieved, which is really the number one goal of the EQIP program.
Olivia, I
Yes.
did want to point out too, most everybody on the call from our Maryland centers are part of the MDPCP program. So
Okay.
the way those objectives align with this program, it it's kind of a beautiful way to do the same thing you're already doing, but another way to get some revenue back in, if you will. So I just wanted to, I think I already mentioned that to Jean, but wanted to mention that to you as well. And just so folks, when you're hearing how this is playing out, don't necessarily think of it as, oh gosh, I've got something on top of stuff I'm already doing. This is very complementary and just maybe another way to bring in some revenue.
Great. Thank you so much for adding that. Okay, so now that we've talked about the cost piece of the EQIP program, I do want to go into the quality measures. So there are 4 quality measures that are included in the EQIP program. We have advanced care plan, medication reconciliation, and BMI. And then we have unplanned readmissions if it would apply. And so the biggest takeaway with these quality measures is that to receive credit, they must be submitted through your claims using the CPT2 or G codes. And this must be done at least once by any practitioner who sees that patient within 1 year prior to the end of the episode. So any episodes that would be attributed to your entity or your group of participants in this program would need to complete the following for those quality measures. This is, again, something that is important to note. Maybe you are already doing some of these quality measures, or maybe you're checking medication reconciliation, but if you're not submitting the actual CPT2 or G codes that correlate to them for the EQIP program, you would not be getting credit. So it's really important to take a look at what those submission codes are. And so on the screen now, I have a little bit of an overview of each of the quality measures. I'm not going to read through each one. We'll again share the slides so you can look into them. I also wanted to mention on the last slide, these are directly from CMS. So the documentation is linked here if you want to read more about, the particular measure. But the biggest takeaway is that the submission codes, you take a look here. Are you currently using these codes? If you're not, is there opportunity for you to use them, as this is, the way in which you would be scored for the quality in the EQIP program. These codes, there's multiple. So for advanced care planning, there's 2, MedRec 3 and BMI 5. Any of the codes would need to be submitted in order to get the credit. All right, so now that we've talked about the 2 main aspects of the EQIP program, both the cost and the quality, we're going to talk about how your overall performance is evaluated. So we already touched on the first part, but the first step is to determine the performance period results. So are your total performance year episode costs less than your target price across all the episodes that you're participating in? If the answer is yes, if your costs are less than your target, then you've generated savings. You must also generate at least 3% of your entity's aggregate target price in order for the program to say, yes, your savings are considered statistically significant. And then if you participate in multiple years, you would have to offset any prior year dis savings, which means your cost exceeded your target price before you can move forward with the incentive payment. So as a first year participant, if you're not in this program, you don't need to worry about that at all. But just for your knowledge, the program does require you to offset any dis savings that are generated from prior years. So once we've determined what your performance period results, what your savings are, we're going to move into this middle. So this middle step is to split the shared savings with Medicare. So because this is a shared savings program, the entity would get to keep a percent of the savings and Medicare would retain the other percent. This is based, excuse me, on which tier your entity falls in based on your efficiency compared to your peers at the state level. So if you're in tier 1, you would get 50% of any savings you generate. If you're in tier 3, you would get 80% of any savings you generate. Again, Medicare retaining the other percentage. Then at this point in time, whatever the shared savings split is the new amount that, is your entity earns. But before you get that payment, there is a quality score adjustment. So that's where those quality measures that we just mentioned come into play. So at this time, 5% of whatever your shared savings incentive payment is will be withheld pending quality assessment. So based on how well you performed on the quality measures, you will get to earn up to that full 5% back. So basically, what I'm saying here is you could lose up to 5% of whatever your shared savings amount is, dependent on those quality measures. At this time, whatever amount is left after that quality score adjustment has been made, the final incentive payment will be due to your entity in full approximately 9 to 12 months after the end of the year. And this is going to be paid directly to whoever the payment recipient is. And this will be indicated by the entity during the enrollment period. You'll put down where, the money for the entity would go. So that is really the main performance evaluation. And I want to just take a moment before we continue to talk about what happens if you actually don't generate those savings and your costs exceed your target. The great thing about this program, as Jean mentioned earlier, is there's no risk at the practitioner level. You are not expected to repay CMS if you do not meet your cost and quality targets. However, there are some policies in place to ensure that you are trying to improve both your cost and quality over time as a participant. The first is the dis savings accountability policy. I already touched on the first piece of this, which essentially says if you generate dis savings or your costs exceed your target in prior years, you must first offset any cumulative dis savings before you can get your incentive payment. Also, if you generate dis savings in 2 consecutive program years and are in one of the lower 2 tiers of that tiered shared savings rate, you would have to sit out of the program for 1 year before you could re-enroll. The other policy is the catastrophic quality performance. If your entity is below the 20th percentile benchmark for any of the quality measures for 2 consecutive years, you would have to sit out before you could re-enroll. Again, nothing to worry about here, especially as a first-year potential participant, but I just want to make sure you are aware that these policies do exist. Okay, so now that we've gone through the main presentation, I want to take a moment to talk about the eligibility requirements to actually participate. So first is you must be a licensed general practitioner, specialist, or other CMS approved practitioner in the state of Maryland. You must also be enrolled in the Medicare Provider Enrollment Chain and Ownership System, or PICOS. You must use a certified electronic health record technology, and you must be onboarded with CRISP, which is Maryland's Health Information Exchange. Specifically for the onboarding with CRISP, if you're not onboarded with CRISP, that's something that the CRISP team would be able to assist you with. The last piece is meeting the EQIP volume threshold in that baseline year. This is what Gene was mentioning earlier when he said you can submit a baseline report and you can basically give all the MPIs of the practitioners you'd like to enroll, and we will see your baseline volume and we can tell you where the opportunity is and what episodes you meet the criteria for. So you don't need to guess during this volume threshold part. I do just want to help you start to think about what the thresholds are. So the first is that you must have at least 11 or more episodes per episode that you would like to participate in the baseline year. So for example, let's say you wanted to participate in diabetes, the diabetes episode. Your entity or the group of NPIs that you're going to enroll with need to have at least 11 episodes attributed to those practitioners in 2019 to select the diabetes episode. Additionally, 50 total episodes must be in the baseline year across all episodes you wish to participate in. So if you want to participate in diabetes only, your entity must have at least 50 or more diabetes episodes in the baseline year. If you want to participate in diabetes and low back pain, let's say you had 25 diabetes episodes and 25 low back pain episodes, you would meet that 50 criteria. It has to just be 50 across all episodes you participate in. And lastly, 75% of the MPIs in the entity must contribute to that overall volume. So they need to be contributing to the 2019 baseline volume. Again, I hope I'm not stressing you out with all these numbers. You don't need to calculate these volumes thresholds on your own. By submitting a baseline volume report or request, the CRISP team can tell you what your volume is. And with that being said, I'm going to pass it over to Angelica from the CRISP team to just talk a little bit more about next steps and upcoming enrollment.
All right, so for this year, the EQIP enrollment, the portal is opening on June 29th, and it will only accept applications through August 21st. With more and more applications, we've planned to give ourselves a little more time so we can make sure all entities' applications are completed correctly and to minimize the errors in the process. So that's why we're closing it a little earlier this year. So that's the August 21st date. We just want to give enough time to make sure the applications are reviewed and processed. And then if you are brand new to the EQIP, to the CRISP portal, you have access, or if you have access but would like to create a new entity, for example, say you're in an entity and want to do some restructuring of that entity, we encourage you to complete the pre-enrollment form. And this is basically you filling out the form, kind of saying how you want to structure it. It'll help us set you up beforehand so you have access to the application, because the application is in the EQIP portal. So it's in the CRISP portal. So without that access, you won't be able to do the application. So that pre-enrollment form will help us set you up in there. So it's a seamless process for you. And it's that application, that pre-enrollment form is not the application. So just want to make sure that's clear to you guys. It's just the process for us to set you guys up. And it takes a few weeks for us to get that access set up. So we need to have that enrollment form no later than August 7th so we can set that up in the back end. And the sooner you can provide that to us, the better. And Olivia was talking about this before, the baseline volume report. You can submit this baseline volume report to determine the opportunity to participate. We encourage everyone to do that because it does give you all the information. Like Olivia said, it's way too much, like you guys, for you to have to try to figure out the episodes and everything. So we kind of do that all for you. We generate that report, send it back to you so you can see what episodes you are eligible for, what you guys have a good number of, what makes sense for you guys to join in on. So we do highly encourage that. It's a great tool for you guys to use. And like I said before, please complete the official EQIP application in the EQIP entity portal by August 21st. And to give you a little bit more information about that enrollment process, there are a couple of changes from previous years, the way the portal looks and everything. We do encourage you to register for the EQIP Open Enrollment webinar, which is going to be held next Tuesday at 12 p.m. And Olivia included that link right there on the page as well. And some entities do ask us, oh, we've already applied in the past. Do we have to do it again? Yes. Every year you do have to apply. Things change. So we want to make sure that everything looks good in the portal so you're ready for the upcoming year. And if you do have any questions or need any assistance, please don't hesitate to reach out to us. Our email is there. And then the MedChi team also is a great resource. Thank
Great.
you. I'll turn it back to you.
Thanks, Angelica. And just to echo again, one more time, I would really encourage everyone who is even maybe just interested to fill out the pre-enrollment form. You're not locked in. It's not the application or anything like that. So fill that out, submit your baseline volume report, see if there's opportunity to participate. And then the open enrollment webinar is really going to be a step-by-step. This is how you complete the application. So again, even if you're not sure, but you just want to make sure you're informed, that's another important meeting for next week. So we'll end with this. Some additional resources are linked here on the last slide. You can plan for CMS vetting. So if you're planning to sign up for the program, CMS vetting will occur after enrollment closes, just to make sure everyone, is in good standing with CMS and able to move forward. So you can do some things to check your PICOs, ensure your information with Medicare is all accurate and updated. We also have the EQIP curriculum, where the program is really broken down into smaller learning modules. So if you're interested in learning more about quality, costs, or participation, eligibility, you can go and watch short 5-minute or less videos, see different guides, strengthen your knowledge about EQIP. I also wanted to point out that we have an EQIP subgroup that meets every other month on that third Friday of that month at 9 a.m. This is open to all EQIP stakeholders. So again, you're not locked into participating if you want to join, but all EQIP information, updates, program discussions will take place here. So you're absolutely welcome to join the subgroup distribution list and, get those emails and invites. And all of the prior meetings are linked on the slide as well. I don't think I talked about this, but very last thing on my end, we do have a MedChi EQIP email. So both the MedChi and the CRISP teams, their emails are listed on the screen here. So if this meeting was interested, but you're still not sure about it, you want to schedule an individual meeting to learn more about if it fits for you, please feel free to reach out to us and, we can set up some additional time or share some additional resources with you. So with that being said, that concludes the formal presentation for today. Jean, I don't know if you have anything else that you want to add before we close out.
Nope, just appreciate the opportunity to talk to you guys, and we're happy to meet with any one of you one-on-one.
Yeah, I just wanted to thank you both and Angelica too, to just thank you for hopping on today. This has been informative. If you had to leave us with one nugget, I don't want to paraphrase, but we're pretty risk averse right now. But the way you described the DIS savings and maybe having to pay it back on a good year, but not really. The risk is pretty low for centers that have had a journey of very high performance since 2019, with 2019 being the base year, right? Is that a good way to frame it for our
At the
folks?
center level, the risk is really zero because there's really no downside risk. The risk is borne at the state level. So, what I would suggest is everybody should do the opportunity analysis. They should fill the form out and find out what they're eligible for. And I know somebody from CRISP or MedChi is more than happy to meet with the center and talk through it. And you can make a decision whether it makes sense or not. But we
Perfect.
had some primary care practices who did it for the first time last year, maybe it was 2 years ago, who got pretty substantial shared savings.
Yep. Yep.
So
I would,
you're not going to get. I don't think you're going to get incredibly wealthy, but for a primary care practice to get an extra $10,000 or something like that, on top of the fact that you're getting a 0.25 increase on your modifier and you can get an advanced payment bonus, those are all pretty nice things.
yeah.
The advanced payment bonus for this year, what is it, Olivia, for the current year? It's
Three,
3 point something.
I think it's 3.1. I will say CMS, to my knowledge, has not actually announced it. I know that, we've
It's in a
seen,
statute though, so I think it's
yes.
going to happen. But so that's a pretty huge, that right there could be worth doing the whole program. It's just to get that 3% if they do that again. So it
Yeah,
just seems that at least looking and see what's available, you know.
absolutely.
Yep.
Well, we really appreciate the time and we appreciate so many centers being able to hop on the phone, even off camera eating lunch. We appreciate your time and thank you so much to our colleagues at MedChi and CRISP as well. Appreciate everybody and have a wonderful rest of the day.
Thank you.
Thank you too.